Hi, I'm Dr. Alan Zieker, and what I'd like to do today is give you some information about various conditions of the eye that will allow you to understand what might happen during cataract surgery and how your eye works as a visual system. Cataract surgery is a very successful procedure, and the more you know about how it interacts with other problems that you might bring to the table will be very helpful to you in understanding what complications may occur and how your vision will improve after cataract surgery. The eye is actually very much like a camera. It has all the components that a camera might have and will give us the same result. Our visual system consists of two eyes, which are two cameras, the optic nerve, which exits the back of the eye, and that goes to the brain. So our visual system is two cameras, two optic nerves, and one brain to interpret the images that we see with the cameras. That's all the eye actually does, is to take a picture. The many components that comprise the eye will start at the front where there's a cornea. It's the window of the eye. Then you have the iris, which is an opening and closing aperture which allows more or less light to get into the eye. And then you have the lens of the eye. When the lens is clear, we can see terrifically. When the lens is cloudy, it blocks the vision, and this sits right behind the pupil, so nothing can get into the eye when it gets really, really cloudy. There are various degrees of cloudiness, and these are early, medium, and very extensive cataracts as they get denser and harder to see through. The light that passes through will eventually focus in the back of the eye. There's two kinds of vision in each eye. The straight ahead vision allows us to see detail. That focuses on the macula. I'm sure you've seen at some point where you've had a magnifying glass, a piece of paper, sunlight coming from above. You can focus the light onto a piece of paper with that magnifying glass. That's how sharp the focus can be. And the eye does the same thing. That focuses to a point called the macula. When the macula is functioning very well, we can see detail. And that detail allows us to read, see license plates, drive a car, and recognize people at a distance. The remainder of the retina, which is the other 99% of the retina, is actually meant for peripheral vision. That peripheral vision helps us find our way and use three-dimensional vision going downstairs, all types of things where it's quite helpful with us. We need peripheral vision, but our detail vision is still the macula. When you have a cataract in the center of your pupil, that blocks that straight-ahead vision especially, and that's why we remove the cataract and replace it with an artificial lens. Patients who have cataracts and diabetes have two problems to deal with. The diabetic issue is one where the blood vessels in the back of the eye can sometimes leak. They can leak with or without cataract surgery. That's what's known as diabetic retinopathy. And the longer you have diabetes, the more this can become a problem. Diabetes, as you may know, is compromised by two issues. One of them would be sugar, and one of them is a blood vessel issue. When you have blood vessel issues with diabetes, it can affect your eyesight in the retina, your kidneys, or your toes. So we know it's not just a sugar problem, it's also a blood vessel issue. So when we do the cataract surgery in the front part of the eye, we don't go anywhere near the retina. But a lot of patients with diabetes will already have leaky blood vessels. The blood vessels can leak fluid, they can leak fatty material. This can get into the retina and cause loss of vision. So if we have a patient who has an eye with cataract in the front, diabetic changes in the back, the portion of the problem that we can fix will be the portion caused by the cataract itself. What they have going on in the back can't be fixed by the cataract surgery. It can, however, once it is seen better after the cataract is removed, sometimes we can actually do more work with laser in the back of the eye to improve the function of the blood vessels and actually make the diabetic retinopathy better. So if you have both problems, this is 50%, this is 50%, the portion of your visual handicap caused by the cataract will be 50%. If it's 60-40, 70-30, that's the portion that we can fix. The remaining portion will be your diabetic problem. In addition, when we do cataract surgery, we're working only in the front of the eye, as I mentioned before. That will create a very microscopic amount of chemical which will pass through everybody's eye during cataract surgery and soon after, in the ensuing weeks. That little bit of chemical will get to the focusing point, the macula in the back of the eye, and can cause a little swelling or edema. If you bang your ankle, it swells, that's water and that's edema. If you get a little microscopic drop of fluid here in the macula, that's going to blur your vision. Rarely is it significant. It can happen in small amounts, but it usually doesn't cause a great problem. So a non-diabetic can have surgery, get a little bit of fluid there, maybe 2% of the time. A diabetic might get fluid back there 10 or 20% of the time. We give all patients nowadays medication a week ahead of time. That medication will help to prevent the buildup of fluid by being there before the actual surgery, so that the medicine is there to prevent the fluid from coming in the first place. That way, your macula stays healthier. Should you develop some edema after cataract surgery and it bothers your vision, it can usually be improved very significantly, 85 to 92% of the time. So even if you do get some, it's not the end of the road. We can do a lot with it, but it is a rare occurrence for it to be significantly bad. If you have hemorrhaging because you have severe diabetic retinopathy, remember, I'm only working in the front part of the eye. Things can happen in the back part of the eye as a separate process. At this point, we've already discussed cataract surgery. You know you're going to have some cataract surgery. There are two choices. The first choice is the lens that is paid for by insurance. There is another lens selection which is not paid for by insurance. This is called a premium intraocular lens implant. The standard lens gives us good distance focus, and with that and a small fine-tuning with glasses if necessary, you can see good in the distance, but you won't be able to read. If you want the ability to be able to see far and near all at the same time, that requires a very special implant. Over the past 12 years, I've been putting in all the different types of implants that have been invented to achieve this goal. So I've seen everything that's been in the marketplace. We've had some very good success with these. The most recent success has allowed about 80% of my patients to be 100% eyeglass free. 20% of my patients have been 80% eyeglass free, and they're quite happy with this result. These premium lenses, however, as I mentioned, they're not paid for by insurance, and they do cost extra. They allow us to see good in the distance as well as read. The intermediate takes a little while for that to gel, but the intermediate does come in. If the intermediate doesn't come in and you want to use a computer, you just bring it a little bit closer and that should be fine. But I want to impress upon you that the premium lenses do allow you the most freedom of anything from glasses. Now, there is no perfect lens. The natural lens you have, typically you needed glasses for far and for close-up vision. They also developed cataracts. We have to take the natural lens out. The standard lens, as I mentioned, is good, but it's only for distance. So these lenses are our current best attempt to give you freedom from eyeglasses. As we were talking about the multifocal lenses, we basically talk about how they function. They allow you to see both distance and near, as well as intermediate. The intermediate vision may take some time to actually come to fruition before you can use it with any degree of ease. If you have trouble with your computer, you can move it a little bit closer, and that will work greatly to allow you to see in that distance. The standard implant, you can see far away, and you will need glasses to read. The multifocal, you won't need glasses to read. The multifocal functions because it's made of a series of rings. If you were to drop a pebble in a pond, it would make a series of ripples. And that's almost what this lens looks like, with circles going outward toward the exterior part. Each one of these rings will create a focus, but at nighttime, it will create a little bit of a halo effect. The halo effect is typically not too bad in the beginning, but it actually gets better. Over the course of 6 months, most people say the halos virtually disappear. The majority of the patients in the first 3 or 4 months don't even get bothered that much by the halos because I have to ask them if they experience the halos. When patients have astigmatism, that basically means there's an abnormal shape to the cornea. If you imagine a balloon that's perfectly round, it has the same curve in every direction. There's no astigmatism there. If you were to squish that balloon from side to side, all of a sudden you have one curve this way and a different curve this way.
A glass basketball, for example, would be perfectly round, and light rays that would pass through would all focus to one specific point. If you had a glass football, simulating astigmatism, the light rays passing through one direction would focus in one place. The light rays passing 90 degrees away would focus in a different place. All the light rays in between would create a line of blur, so the astigmatism creates blurring. When we do the cataract surgery, I've been doing what's called limbo-relaxing incisions to adjust patients' corneas to reduce the astigmatism. We can use surgery to reduce vast amounts of astigmatism, so it's quite easy if the special techniques and instruments are used to try to eliminate astigmatism or at least reduce it to a significant degree, 75, 85, if not 95%. This is something we can do at the time of surgery.
So if we fix the eye with the astigmatism, that means we're taking a cornea which is somewhat shaped like a football and we're changing it into more of a basketball shape so the light rays will come through and focus better in the back of the eye. Cataract surgery is one of the safest surgical procedures there is. It actually is the most common procedure among adults. 2.3 million people had the surgery last year. 98% of the people have no complications if they have no other disease processes. And if you have other things, then the success rate does drop a little bit, but it's still 95% successful, avoiding major complications. What are the major complications? The major complications would be bleeding under the retina of the eye, hemorrhaging inside the eye, a severe infection inside the eye, or actually detached retina. Now, I'm happy to say that most of these things happen once out of several thousand cases. They're very, very rare. A detached retina is a little bit more common, and prior injury, extreme nearsightedness, can sometimes be a little bit of a predilection for these retinal detachment patients. But if you do have a detached retina, that typically can be fixed about 85 to 92% of the time. So the vast majority of patients never experience any of these situations. If you do have a problem in the postoperative period, we want to make sure that you come to us and give us a call as soon as possible, because like any problem, the sooner we get to it, the more we can help you.
Points to remember. Cataract surgery is over 98% successful in avoiding major complications if you do not have diabetes. If you do have diabetes, it's over 95% successful in avoiding major complications. 1 or 2 patients out of 100 may develop fluid in the back of the eye. Medication taken for 2 to 3 months generally resolves this issue. Patients with diabetes have an increased risk of this. 1 out of 2 to 3,000 patients may experience a bad hemorrhage or bad infection inside the eye that can appear within a couple of days or several weeks. These can be devastating to the eye, and happily they are very rare. If these rare conditions occur, the sooner you are examined, the better the outcome. If you are doing well after surgery, and you are improving daily and suddenly you have a drop in vision, pain, discomfort, or headache, call us to schedule an appointment right away. The sooner we catch any changes, the better off you are. We are available 7 days a week and 24 hours a day, including weekends and holidays. This is major eye surgery, not major body surgery. The vast majority of patients do very well without any discomfort. Without a history of trauma or extreme nearsightedness, retinal detachments are very rare. Typically, surgery is successful in repairing retinal detachments.
I hope this has been helpful in explaining to you what can go on with the eye with cataract surgery. And if you have any further questions, please feel free to talk to my staff, and I'm sure they'll be happy to help you.